Okay, guys, so I'm happy to give you the introduction for this evening, generally connecting NLP to mental health. That's it. Let's go. First of all, about myself, although Tanya presented me nicely, I'm Amit. I'm a data scientist here in Eleos Health. I design a lot of the services and the products and the features we have in the data science. The agenda for today, I want to give you an introduction about Eleos, the place you're in, and the idea of care operations, which I'll explain in a second. What is psychotherapy, the specifics of mental health in data, and the specific challenges of mental health AI adoption. I have an echo. It was a Zoom. Okay. And some examples on what to consider when we build the data solutions. So let's start with Eleos, and of course I didn't start the timer. Okay, let's start with Eleos. Eleos was founded 4 years ago by these three founders. We sort of introduced the idea of care operations, which the idea behind it, yes, thank you. The idea behind it is to let therapists deal only with therapy. All the burden around therapy, we take on ourselves. You deal with the things you're best at and the things you like the most, which is therapy. And by the way, we also help you with the therapy itself, but I will talk about it more in a second. So what happens in psychotherapy sessions? Generally, some of you know less and some of you know more. What happens when you go into a therapy session? So first of all, the therapist usually does the initial assessment of you, what you need, what are your problems, what do you want to get to. Then they usually do treatment planning, and then they apply within the sessions themselves. They apply in the session themselves listening skills and intervention. Listening skills are more passive way that therapists use in order to help the patient, and interventions are active strategies they do in order to help the patient. And we can think of all the NLP solutions we can apply on each of these stages. And by the way, all of these needs to be documented really, really well, which is also another burden. We can think about applying AI and NLP solutions to all of them. That's what we do here in Eleos. And by the way, when I talk about this stuff, I talk about the micro level. This is what happens between one session between one therapist and one patient. We can also think about the macro level. What do clinic managers, which have, for example, 100 therapists under them, what do they want to get using NLP? So maybe better outcomes monitoring that they currently don't have. Leadership reporting and compliance, whether, for example, the documentation is aligned with clinical guidelines. Okay, so I talked about what we can develop with AI and NLP for day-to-day practice, but we can even think larger than that, right? Our data here is super, super unique. We have data from real-life sessions, and that's something that in the psychological field doesn't exist in the quantities that we talk about. And that's why we can answer very real questions regarding mental health. For example, let's think about phobias, right? Just as an example. And the idea of טיפול בחשיפה. This is an exposure therapy. Thank you. We can think, for example, of the very interesting question, is systematic exposure, let's say, actually working? And usually before that, in order to answer the question, you would have to, conduct an RCT, maybe do like university academic study. But we have real life data, like real sessions that really happening. So, and lots of them. And when I say lots, I mean a lot of them. And that's why we can answer much more bigger quantitative clinical research. And in the next talks, they will talk about it more. Another cool aspect of mental health that we need to remember, not like other medical fields or a lot of other medical fields where NLP can help in reducing the burden or the surroundings of the treatment. NLP here, think that the text is actually the treatment. Talk therapy is the therapy itself. So in a sense, we can not only just help with the burden, we can actually modify or enhance the remedy. We can tell, it's like improving the medication itself. So this is something, a really cool aspect to remember about mental health. Some numbers of what we achieve with the things we're developing here, and we'll talk about it more. So we obviously reduce time in documentation and doing a lot of automation about the generating of documentation. But we also get like clinical stuff, higher client engagement because the therapist can be much more focused on the therapy itself. We get better symptom reduction because of different stuff that we develop, and we will talk about it. And we get, for example, much more evidence-based intervention. So maybe when therapists have a better visibility to what they did during the session using our NLP solutions, they can apply much more evidence-based techniques. What's so special about mental health? A lot of you come from medical fields and data science and medical fields. Can you guess? What's special about mental health data?
The outcomes are way harder to diagnose correctly and consistently.
That's an issue.
Can you repeat their answer?
Yeah, so the answer was the outcomes monitoring is much more harder. Defining outcome monitoring is really, really hard.
Not a precise science.
Again, it's a qualitative science. You mean like mostly today? Yeah.
Yeah, I was gonna say as well that it's very subjective.
Yeah, right. It's kind of relates all of your responses. So let's go over it. So in mental health, we have much more longer and detailed sessions.
Another difference is you don't have established protocols, guidelines, like you have normal medicine.
Yeah,
Maybe the approach is or dynamic.
right. You kind of do, but sometimes there are sort of like a continuous research rather than evidence-based guidelines. So this is the issue. We have very long and detailed sessions. Sensitive details, it's in all medical fields, but in mental health, it's even bigger. Because think that in mental health, many times the patient doesn't talk not only about themselves, they talk about other people. And they mention their names and their medical stuff. It becomes like a larger scale, more sensitive. A lot of implicity, sometimes, deciphering whether a patient is better or not is really tough. And we have to consider much more body language and tone. It's ongoing and continuous, not like many other medical fields, which is 1 session, 2 session, 3 session. Here it can be months long of treatment. And we have much, because of the sensitive detail stuff, people not only talking about themselves, we have much more frequent entities confusion. Again, so we can have, because of this confusion, we can have sometimes summaries that confuse between the entities. Why is AI adoption more challenging in mental health? This is relating to the point I talked before, in which in mental health, the conversation is the treatment, meaning that therapists are much less likely to adopt these kind of solutions because they are not only afraid their data will be leaked, they are afraid it will hurt the treatment itself. Like trust is really important in order to do it. So this is a very large obstacle. Technically, how does this happen? Okay, so I talked about a lot of solutions we can apply to even to day. Let's focus on one of them and go quickly. Documentation. So documentation in mental health usually consists of several fields they have to fill, they have to complete after a session was done in order to, see in a larger scale what happened during the session. So they have usually a data section in which they describe what actually happened, assessment, which is more clinical assessment. The patient looks depressed, more tired, sleeping problems, and plan. What do they, considering the assessment and the data, what they plan to do on next to help the patient. But of course, it has to be much more complicated. It's not the only type of clinical note. There are tons of them, and here I gave only the most common ones. Actually, each clinic can develop their own kind of note and what kind of information they feel in their documentation, which makes it more complicated problem. Okay, so how do we step in and help in documentation? So we can think about two solutions to go about that. We can think about putting a recorder, right? And do it all passively. Like listen to what happened and then just give them the documentation. They don't need to press anything. The recorder is there, does anything for them. And they can actually maybe more aligned to what a lot of therapists do, that they write notes during the session. We can take their notes and help them, usually it's like bullets. They don't actually write in details what's happened. And we can take these, sketches and make them like a clinically written note. Okay, so we have these two pipelines that we can use in order to apply NLP on documentation. Let's go over quickly on these pipelines. So again, this is a very large scale. So obviously the first part of the pipeline is we have recording. We need to make it a transcription in order to make it a text. We need then, after we have the transcription, we just have, a bunch of text. We need to divide it into speakers, speaker 1, speaker 2, speaker 3, if it's a more than 2 people therapy session. Then we need to identify what, speaker 1, is it the client or is it the therapist? And then we need to do a lot of classification. Think about a 45 minutes therapy session. A lot of stuff is what we call it's kind of garbage. It's not interesting to the summary or to the mental health. So we need to classify a lot, like what parts are more important, what parts were applied intervention. A lot of classifications needed to be done here. And in the end, we need to summarize. Okay, this is basically it. Of course, it has a lot of variations. And the non-recording based pipeline is a bit simpler, right? Maybe we take their sketches of what they wrote, we classify them because each sketch is related maybe to a different field. And then we do like the other way around, and summarization is like paragraphization, make it larger and more clinically written. In the end, how does the UI look with these pipelines? So for recording live, they actually just get in the end suggestions of what happened. You can see here the note itself, and they get the suggestions that we give them in the end of this pipeline. For non-recording based pipeline, they need to do some active stuff, right? Write bullet points here. And then when they click generate note, it takes the bullet points and makes it paragraphs for a clinical note. So good, and I have time. And we can think about which type of solutions and models we apply for each stage. So we can think a lot about, I will give here a lot of options. For recording, we can use, to have a better recording and to identify voice better. So we can have recorders, some of them are smarter. We get maybe sometimes even AI-based recorders. Or we can use much more simpler solutions like Teams, Zoom, all these kind of recorders, and use Python, usually Python packages in order to reduce noise, identify speakers, identify voice order, and so on. When we get to transcription, we can use models which are out there, or we can use, a lot of known and out there solutions that we can directly use. And then we have, let's say we have transcription, a lot of text. Then in the speaker recognition and speaker identification becomes maybe a bit of more complicated problem. We need to do a lot of clustering to cluster voices and match them to a specific text within the transcription. And we can use maybe sometimes when we have speaker 1, speaker 2, we can use maybe simpler classification models in order to understand which is the therapist and which is not. In that sense, it's nice to note that we have more and more dedicated models for ASR that kind of combine many of these stages together. So we don't need to separate between transcription, speaker recognition, and identification. We can just put it all up together, and it gives us a full-on transcription in the end with separated by speakers. And in classification part, it depends really much on the test complexity, but we can use simple classifiers or small language models. It doesn't have to be very large language models. Sometimes it can be really, really small ones. Or we can use, and for the summarization paragraphization, we can use smaller language models or large language models, again, depending on the test complexity, or, out there LLMs. And also here we have solutions that kind of combine the two. For example, what? Wait.
Maybe spoiler.
Yeah, it started jumping. Okay. And we can combine the two. Maybe classification and summarization can be done by the same language model at once, and it doesn't need to be separated. Okay. So I will finish here. I just will say that a lot of modeling consideration take part when we analyze these pipelines and we create them. Obviously, like all of you, latency, task complexity, time to develop, and cost. This depends, this makes us make the decision whether we go with the smaller language models, maybe we go with BERT, maybe we go with ChatGPT, maybe we go with Amazon Transcribe. It really, really depends on what we want to develop here. And oftentimes we don't need, OpenAI or very large language models. Maybe sometimes even rule-based stuff are like the best solutions for simpler tests. So key takeaways I want you to take from this. NLP application enhances treatment and it benefits the psychotherapy field, both in day-to-day products and overall we can do much larger clinical research. And we have very field-specific layers of data sensitivity, as I told you about, the entities confusion, the other stuff we talked about when we talked about the specifics. Technology adoption is a bit harder. And again, like a lot of medical fields and data science, we take into consideration innovation versus simplicity whenever we develop a data or a model solution. And that's it. That's the introduction for today. Now, I will present